Okay, we're going to go ahead and get started. Thank you for joining us for the second of 4 sessions of Leukemia Research Foundation's New and Emerging Treatments series. The topic of this session is CLL, and we're joined by Dr. Catherine Coombs from UC Irvine in Southern California, who will share some slides about the latest treatments and research for CLL and respond to questions from participants. My name is Lindsay White, and I am the Director of Programs and Partnerships at the Leukemia Research Foundation. I would like to take a moment to thank our supporters of this series. We received support from AstraZeneca, Autolus, Kite, Merck, and Pfizer. The Leukemia Research Foundation's mission is to cure leukemia by funding innovative research and supporting patients and families. The foundation has raised over $90 million in support of its mission since our founding in 1946 and has funded research grants to over 700 investigators worldwide. Our support programs for patients and their loved ones include information and education programs. We also provide some financial assistance, and we have a directory of other helpful organizations on our website. For today's program, all participants will be muted, but we welcome your questions in the Q&A box at the bottom of your screen. If you already submitted a question at registration, we have the questions. We've gone through them, and responses to many of the questions will be included in the course of the program, and we'll do our best to get to everything, but we do have many questions, so we'll do the best we can. After today's program, you will be sent a brief evaluation through email. Please, if you can, take a moment to complete that evaluation so that we can improve future programs. Also, this program will be recorded, and a link to the recording with a transcript and captioning will be available and will be sent to participants or to registrants after the conclusion of the program, probably in a week or two. We're grateful to have Dr. Catherine Coombs today with us. Dr. Coombs is a board-certified hematologist and oncologist who specializes in the management of hematologic malignancies. Her primary expertise is chronic lymphocytic leukemia and small lymphocytic leukemia, which has been her research focus for more than a decade as a principal investigator of numerous clinical trials of novel agents that have improved the care of these patients. Dr. Coombs joined UCI Health and UCI School of Medicine after serving on the faculty at the University of North Carolina in Chapel Hill, where she spent 6 years developing a CLL program. Her research is devoted to developing new drugs and novel drug combinations to treat CLL. She also has an interest in precursor conditions that can lead to blood cancers, including monoclonal B-cell lymphocytosis, clonal cytopenia of undetermined significance, and clonal hematopoiesis of indeterminate potential. Dr. Coombs, thank you so much for joining us today. Please, let's get things started with an overview of the latest treatments and research and trials for CLL.
Yeah, okay, great. Thank you for that introduction. I'm gonna share my slides. Can you see these, Lindsay?
Yes.
Okay, lovely. All right, so it's great to be invited to speak here today. I actually find speaking to patients the most challenging because I know many of you are coming from a lot of different walks over the trajectory of your disease. And so I try to cover material in a way that hopefully is helpful for some, and I apologize if it's not unique to your own scenario, but I'll do my best to cover kind of the wide breadth of what a patient's disease journey with CLL looks like and what new and emerging treatments are available along the way. So here's the outline. I'll just very briefly talk about CLL in general, just to acknowledge that people are, again, coming into this presentation probably in a lot of different clinical scenarios. We'll talk about when treatment's needed, what are some just general treatment approaches before diving into the meat of the presentation, which is what are the newest treatments, whether that's patients who are needing treatment for the first time or patients who are needing treatment for the second time or beyond. We'll talk a bit about the role of clinical trials, including a couple new and exciting drugs that are under development, and conclude with a little bit related to the role for second opinions. And then, of course, we'll have time at the end for your questions. So CLL, as I'm sure many of the audience know, is one of the most commonly diagnosed leukemias. It's the most common leukemia in Western countries. A common question, including one that I saw leading into the presentation, is the difference between CLL and SLL. CLL is what we use for patients who have a leukemic component of their disease, which just means essentially a decent amount of circulating clonal white blood cells. SLL is just the preferred term for when there's not a leukemic component, meaning not a significant elevation in the white count. But for the most part, we treat these two entities the same exact way. And so that's why you often will see CLL/SLL. And so realize the therapies that I speak about, if you're an SLL patient, apply to you, even if the talk is titled CLL. It's mainly an idea that this is a disease that can involve many compartments within the body. And so most commonly it involves the blood, almost always will involve the bone marrow. However, there are some patients where it only involves the lymph nodes. And again, that's when we use the term small lymphocytic lymphoma. But these are the same cancerous blood cells, and they all arise from B cells, which are a type of white blood cell. We use different prognostic tests in determining what a patient's clinical course will likely look like. The reason for this is there's a lot of heterogeneity, meaning some patients don't need treatment at all. About 1/3 never need treatment in their lifetime, but some patients can follow a more aggressive clinical course. And so a number of different tests have been established to help us get a better sense of who are the patients who are less likely to be sick from this disease that maybe we don't follow as frequently versus the patients that we should keep a closer eye on. And these tests also become relevant when we talk about both our existing and our emerging treatments, because some treatments work either better or worse depending on what subtype of CLL an individual has. The CLL International Prognostic Index is a way to sum up kind of all the different prognostic markers that a patient has, and it can divide individuals into one of 4 different risk groups, ranging from low risk, where most people are not going to need treatment, out to 5 years. 78% of people don't need treatment, compared to the very high risk patients, where literally all patients are going to need treatment within 5 years. And so that's why it's important. And so there are these different curves that you can look at that, number one, predict survival, but realize the survival estimates are not very accurate because these patients, including in this probability model, mostly didn't have access to the drugs that you all have access to today. But the curve on the right, I find very helpful in counseling my patients because a common question is, hey, doc, I don't need treatment now. When would you expect for me to need treatment? And so by figuring out what risk group you're in, then we can be better informed on, hey, treatment may be, statistically likely to be needed in the next 2 to 3 years for the higher risk patients versus, hey, all odds are that you're not going to need treatment even 10 years from now. So delving into the big question is what do we do with treatment? Well, again, I'd like to emphasize about 1/3 of people never need treatment in their lifetime. However, that means the other 2/3 do. And so that could be either after many years of watchful waiting or active surveillance, although occasionally it can be shortly after diagnosis for some. However, the standard of care in 2025 for patients who have CLL but have no symptoms from the disease is active surveillance, also termed watchful waiting. However, the caveat to that, and this is kind of a new and exciting treatment option, is that we do have clinical trials for patients with higher risk CLL to help determine if there is a benefit for early treatment. But these trials have been done in the past, and at least as far as the clinical trials that have been completed to date, there is no proven benefit of early treatment. And so that remains experimental. If there's time at the end, I will mention an ongoing clinical trial looking at what we call early intervention treatment, because again, we're trying to determine now that our treatments have gotten so much safer and so much more effective, could there maybe be a role for treating some of our highest risk patients before symptoms come about from the disease? But the main focus will be on two different types of treatment, as I call them. And so the terminology is listed at the bottom of the slide. Frontline or first line therapy, this is the term we use for when patients need treatment for the very first time for his or her CLL. The next term is relapsed or refractory. And so these terms refer to patients once the CLL has returned after the initial therapy. And so sometimes there will be therapies that are specific to the first relapse, meaning the second treatment, or the second relapse, meaning the third treatment, and so on. And so just for level setting, I wanted to throw those terms out there so we can follow the rest of the presentation. And so there are very standard guidelines on when we should start treatment. Typically, a patient is developing symptoms from the underlying CLL, and either that could be that the bone marrow is not working so well and that the patient now has anemia or low platelets, the spleen is very large, the lymph nodes are very large, etc. Even though the white blood cells are tempting to follow, I would encourage you not to get too fixated on them, because the rising white cells alone is only rarely a reason to start treatment. And so I've probably treated, several hundred patients with CLL, and based on the white count, I've only treated maybe just a couple patients, because that's just not very common. Usually one of these other things is going on. Another question that I saw in the chat relates to, well, what can we do about the increased risk of infections with CLL? And I will admit that even in current time, where we have so many advances in our prevention strategies for many cancers, there has not been a great way of preventing infections in folks with CLL. However, treatment of the CLL does not improve the risk of infection, and it can actually make it worse in the short term. So there are other adjunctive ways to help minimize the risk for infections, especially among patients who have low immunoglobulin levels. But that doesn't actually treat the CLL, it just supports the immune system. So we won't spend a lot of time further on that, but because that's a common question, I wanted to bring that up. So now, what are our new treatments for CLL? And so in 2025, we have two main approaches for treating CLL when it's the patient's first treatment. And we divide these into two separate major categories. One is considered a treat to progression type regimen. And to make that simple, the idea is that you go on a pill and then you stay on this pill to keep the CLL under control, and eventually it goes into remission. But in general, you need to stay on the pill to keep it in remission. Of course, there are exceptions to this, but that's the general approach. And for anyone who's been on drugs like ibrutinib, or kind of the newer generation of drugs like ibrutinib, such as acalabrutinib and zanubrutinib, those treatments all fall under this model. The next broad way of treating CLL is what's called a time-limited therapy. This is a general term that we've kind of been using for the idea that you can go on a combination of medicines to knock the CLL down to a very low level, often an a segue into what are the new treatments that we can expect. And so the time-limited therapies are attractive because the CLL can go into a very deep remission. It's like you don't have CLL anymore, but recognizing it's unfortunately not a cure, and no one's been smart enough to fully cure CLL yet, but that is something we're all working towards. And so the commonly used treatments, as I alluded to, are either the continuous use of a BTK inhibitor. The time-limited regimens are going to be employing a drug called venetoclax. So the traditional kind of tried and true way of using venetoclax as a frontline treatment is with a drug called obinutuzumab. You may also see it combined with rituximab, but that's usually done in the relapse setting, not as the first treatment. And actually, we in the United States prefer also to use obinutuzumab in combination with venetoclax in the relapse setting, although technically it's not FDA approved that way, but it is approved by, it's listed in our national cancer guidelines. So that's why insurance usually is willing to pay for it in that setting because the drug obinutuzumab is more effective. In the past, you may have seen the use of chemotherapy, and these drugs regimens do work for the CLL, but because they can be quite toxic, these are no longer favored in the current time. So the newest frontline treatment regimen that I am hoping to see an FDA approval for by the end of the year is based on a clinical trial that was called Amplify. And so just to help understand where this came from, we know that the use of venetoclax works very well, both for patients as their first treatment and subsequent treatments. Combining it with the drug acalabrutinib, which also works well to treat CLL, is very attractive. And the idea is if we combine these two drugs together, that we can then get patients into very deep remissions where the treatment can then be stopped. And so this study included several hundred patients with CLL, where a third of them got kind of the old-fashioned chemo, another third got the acala pill, also called Calquence, and then venetoclax. And then the other third also got the addition of this obinutuzumab, also called Gazyva antibody. And so the message of the study is both groups of patients that got acalabrutinib and venetoclax, whether with or without the obinutuzumab component, had much better response of the CLL, and it took longer for the CLL to come back as compared to the old-fashioned chemo. The highest responses were seen in the patients that got the 3-drug regimen. However, the 3-drug regimen had an increased risk of some toxicities, mainly infection. And so, as far as where this stands at time of the presentation, it's not yet FDA approved, though that is anticipated. However, it has been listed in our National Cancer Center guidelines. And so often this is enough for insurance to approve this new treatment. The beauty of the A plus V regimen is that it's 2 pills. So it's really nice to not need an IV therapy. It's a treatment that's given over 14 cycles. So you're done with treatment after a little more than a year. So a lot of questions leading into this talk asked, when can treatments be stopped? And so if you do a time-limited treatment, the plan is always to stop after the planned duration. However, if you're doing treatment with a drug of the treat to progression class, the go on and stay on pill, in general, we don't proactively recommend that you stop. However, there have been studies looking at patients that did stop because, say, they had some side effect. And some of the emerging data suggests that often the CLL can stay in remission for a couple years, especially for patients who stop at a time when the CLL is under good control, meaning the blood counts have normalized, there aren't swollen lymph nodes, etc. And so I think we'll be seeing more studies related to stopping these drugs early, but in my own practice, I do have an open mind when a patient approaches me about, could I stop this drug? And we then would have a conversation about the risks and benefits. So a big question is, we have great frontline treatments, but what do I do when my CLL comes back? So we know that CLL can be highly responsive to multiple drug therapies, even in the relapse setting. And so what do we use in the second line setting is highly dependent on, well, what did we use in the frontline setting? And so if a patient for example, started on a BTK inhibitor, a ibrutinib or a related drug like Acala or Xanu, usually my preference would be to switch over to a venetoclax-based treatment as the next treatment, and then vice versa. However, if someone started with venetoclax-based treatment and then relapses, say 4, 5, 6 years later, you also have the option of repeating venetoclax because the CLL should not be resistant to it, given that you had a long break between the treatments. And so the next question is, well, what do I do if my CL comes back again? And so third line treatments and beyond. And so this is where I'd like to talk about two really promising and newly FDA approved treatments that can be used as the third treatment or later. So the first is a drug called pirtobrutinib, also called Jaypirca. The other one is kind of a mouthful. It's lisocabtagene maraleucel, also called Lysocel for short, and the brand name is Breyanzi. So the first thing I'll say is both of these drugs can be quite effective. And so the first one, pirtobrutinib, was first approved in December 2023 by the FDA under what's called an accelerated approval mechanism. And so the idea is the FDA approves drugs before kind of the confirmatory studies have been completed because they want patients to have access to these drugs. But with the understanding that there will be some more studies kind of further cementing this approval and understanding where this can be used in the future. The current FDA approval is for patients who have already had a covalent BTK inhibitor, so like acalabrutinib or its cousins, and venetoclax. And the exciting thing about pirtobrutinib is it's the same exact target as drugs like ibrutinib, BTK inhibitors. So this drug inhibits BTK, but it still works even when the BTK protein has had a mutation, because instead of being an irreversible binder, it binds this protein reversibly. The best part about this drug is it leads to high overall response rates. So around 80%, meaning 4 out of 5 patients that get this drug are going to have a favorable response. And it also has a very excellent safety profile. So very few patients need to stop this drug due to side effects. So what is the future for pirtobrutinib in CLL? A new study was just reported in December and actually was just published within the past 2 weeks that should lead to the full FDA approval. And the premise of this study is that maybe we can even use pirtobrutinib before venetoclax. And so it also, I think, is likely that we'll see this broader full FDA approval where you don't have to wait until after venetoclax to get pirto. You may be able to get this drug before. The beauty of the drug is, number one, it works quite well in most patients. Number two, it's very safe and easy to administer. So it's a pill that doesn't require any special monitoring the way that venetoclax does. It is also being studied in earlier lines of treatment, but I anticipate it'll take a few years to see results of those studies. So the other new treatment that I'd like to mention is lisocabtagene maraleucel, Lysocel. This is a CAR T product, and so you may have heard about CAR T. They've been in a lot of news in the lay press. It's a pretty complicated way of treating cancer, but it has proven extremely successful in acute lymphocytic leukemia and other types of lymphoma. And it's only recently been approved for CLL in March of 2024, so a little over a year ago. The premise behind CAR T cells is that we take hopefully healthy T cells from a patient's body through the vein, and then these are manufactured in the lab to become little cellular warriors that get reinfused into the patient's body. And then because of the genetic engineering, they're kind of engineered to fight the CLL. And so as a result of the study of about 50 patients with CLL, this was also FDA approved under this accelerated approval mechanism and will be undergoing some confirmatory studies also. The way that I see the data for CAR T cell is a bit of a glass half full, glass half empty view. And so I'll give you my optimist take first. It is honestly the only drug we have that can be given once. So this is a one-time treatment that can lead to what we would call very deep responses, meaning patients get the CLL completely undetectable in the blood, all of the lymph nodes normalize, etc. And so no other drug can do this once patients have had at least 2 other treatments. However, the glass half empty view is, well, unfortunately, these deep responses are only seen in a minority of patients, around 20%. So about 1 in 5 patients is lucky to get this really deep response, meaning the majority of patients won't have this deep response. And it also can be associated with some more serious toxicities, such as something called cytokine release syndrome, neurologic events, and delayed blood counts. And so a lot of the remaining treatments I'll talk about are not yet FDA approved, but they are being studied in clinical trials. So a few words on clinical trials is these are really important ways of getting new drugs to more patients because we study, number one, how they work, and two, how safe are they to ultimately be able to give more CLL patients the safest and most effective therapies. So one drug that I'm excited about that's under study is what's called a bispecific antibody called epcoritamab. And so this is given as a shot. So it's not like infused through an IV. It's a subcutaneous shot that actually is FDA approved for other types of cancers, just not CLL. It's currently being studied in CLL, and in a study of CLL patients who had a lot of previous treatments, meaning the CLL is a little trickier to get under control, they saw a good overall response rate where about 3 out of 5 patients did respond, including about 40% of patients getting into a deep response, a complete remission. The problem with this drug is it can lead to a side effect called the cytokine release syndrome. This is almost like you have the flu, and maybe a bad flu. You can get high fevers, sometimes low blood pressure, but they're working on how to minimize this side effect by changing the way the drug is given and with a slower escalation to get into the full dose. So I'm excited about the future of this drug. The other drug I'm really excited about, there's actually a couple drugs that are in the same class. And so we know that targeting the protein BTK is really important for treating CLL. Usually what drugs do is they bind to it so the drug can't be active. The new type of way of approaching BTK as a target is instead of binding it so it can't work, instead, these drugs called degraders put a hook onto the BTK protein, and then it gets then taken to what's called the proteasome for targeted degradation, almost like a dumpster to get rid of the protein altogether within the cell. So I think this is a really cool mechanism. There's 2 drugs that have shown relatively similar activity, both looking really good. And so this bexobrutideg drug, it's very hard to pronounce, was actually just presented at the conference in Milan last week, the European Hematology Association meeting, where we saw an update to the clinical trial. And this drug shows that 81% of patients with CLL responded. So it looks very effective. The safety also looks good. It is hopefully going to be studied in some more advanced trials, such as phase 3 studies that may lead to an FDA approval, but that may be a few years away. Another drug is very similar. It's being developed by another company called BGB 16673. It overall shows pretty similar response. So we may have a couple drugs that work in a similar way that can be used even after ibrutinib, acalabrutinib, zanubrutinib, even that other new drug, pirtobrutinib, even after venetoclax, showing that we have many treatments that are available even after the standard treatments have failed you. So here's a list of a few more drugs being evaluated in clinical trials. Of course, I couldn't go through everything, but I want you to know that there are a lot of other exciting drugs under development, and hopefully we can get to a place where no one dies from CLL anymore. My last comment is something that relates to a common question I get at webinars, which is, should I be getting a second opinion? And so I think if you're comfortable with your doctor, it's not mandatory. However, because CLL is the most common leukemia doesn't mean it's very common for doctors who see a lot of other things. And so when you look at the incidence of CLL as compared to the really common cancers seen in the community, it's about a tenth as common, if not even less. And so my advice is if you don't feel like your questions are being answered, it never hurts to get a second opinion. And I even have my own patients who get a second opinion, and I'm never offended by that. And if your doctor's offended, then they may have an ego problem. But that being said, I think so many community docs do an amazing, amazing job of treating not only these common cancers, but CLL. And so I don't think it's something everyone needs to do, but I think if you feel like you're not getting your questions answered, it would be worth it. So with that, I'm going to skip this study. This is just the study design for patients who have CLL on watch and wait that could get enrolled into a study to get early treatment. That may have come up as a question. So we'll see kind of what other questions folks have with the remaining 25 minutes of time. Thanks so much for your attention, and sorry for the technical difficulty.
Thank you so much. I think that was great. And yeah, you bounced back perfectly after that kind of little glitch there. So I'm glad you were able to get quickly back on track. So thank you for that. And before we move on, since you still have your slides up, one person asked about the study drug NX5248. Do you have anything on that one specifically?
Oh, yeah. So it's NX5948, I think is what the person is referring to. That drug is now called bexobrutideg.
Okay.
So Nurix, to my knowledge, has two drugs that have enrolled patients with CLL. This one, NX5948, that they've now given a name to, bexobrutideg, probably is the one that looks the best for CLL, at least based on what we know now. The other drug is NX2127. That one looked okay in CLL, but it looks like that one will probably be developed more for other lymphomas other than CLL, based on just my very, rudimentary understanding. But that drug looks really good. And so it looks like about 4 out of 5 patients who get it are responding. It looks like the safety is favorable, meaning not too many people are having, serious side effects, and I'm excited about it.
Great. We have a couple of questions in the Q&A, and I'm just going to run through them quickly before I click over to the other questions that were submitted in registration. The first one, can Calquence be effective if given only once a day instead of twice?
That's a good question. So Calquence was designed as a twice-a-day drug, and we know that it probably works its best at the twice-day dosing. However, that being said, is I have had a handful of patients who had some type of side effect at the twice-a-day dose that I then bumped down to the once a day. And in my personal experience, they do okay. They've done fine on the once a day. So it is a less well-studied way of doing it. But what I know from my own experience is that it can be fine, especially if patient's disease is reasonably controlled when they do the once a day dosing. There was also a study looking at what happened to all the patients with, who got their dose reduced. So this is again outside of my own personal experience. It looks like the drug probably works about as well if it's your first treatment and you do the once a day dose. However, if it's your second treatment or beyond, it may not work quite as long at the once a day dose.
Great. Let's see. We have, do you recommend an MRD test after treatment if all labs are normal?
Um, MRD, for those who haven't heard that term, it used to be called minimal residual disease, and now we like to call it measurable residual disease. But the idea is that we're looking to see, are there any low levels of CLL present beyond what can be seen with the naked eye or the kind of traditional ways of measuring? It's almost like looking for a needle in the haystack. The role in CLL remains somewhat controversial, so it's not a widely accepted or standard test that has to be sent. In my own practice, I do usually send MRD tests when a patient is nearing the completion of a venetoclax-based treatment, because what we know, at least with the time-limited treatments, the ones that you go on for a period of time and then you stop, what we know is that patients who get to undetectable MRD, meaning we can't find that needle in that haystack, like there's no CLL, even if we count up, 10,000 cells, 100,000 cells, etc. We know people who are negative are the patients who are, number one, going to have the longest period of time until the cancer eventually comes back, and they actually live longer. So I use it as what we call a prognostic tool. It helps us know what's going to happen in the future, as best we can. So yes, I do use it. However, not everyone does. And so if your doctor doesn't do it, it's not wrong. The argument not to do it is, hey, this test is expensive and it wouldn't change what I do, which is that I'm going to stop treatment anyway, whether it's positive or negative.
Okay. There's a question that was submitted earlier in the registration, specifically about acalabrutinib for a 17p deletion. What is the preferred drug regimen after acalabrutinib?
What was acalabrutinib or what?
They have a 17 deletion. Is it 17p deletion, I think?
Yeah. So 17p deletion used to be very bad back in the chemo days because chemo does not work well. And that's really changed tremendously with the approval of a lot of these new drugs. So acalabrutinib is one drug that works very, very well for 17p. The other drug that works extremely well is zanubrutinib. And so both of these drugs, when used kind of continuously to suppress the CLL, lead to high rates of remission and control of the disease. Venetoclax also works well in 17p, but what we know is that if you stop venetoclax, the CLL tends to come back a bit quicker than patients who don't have the 17p. So it is still an option, but in general, the BTK drugs, if they're given continuously, are thought to be the treatments that lead to the longest time for the CLL to ultimately grow back and progress.
Great. Okay. We are back to the Q&A. Just I'm kind of going back and forth here. There's two questions about I think it's VO, so venetoclax and I can't say, but
That's okay.
Thank you. Can you talk about the clinical trial for early treatment of high-risk CLL with VO, and then also having achieved MRD, why might my hemoglobin continue to drop? And this was somebody, I guess, who was on that regimen.
Okay. Yeah. So I am excited about this trial. It's one that I've been involved with. So it's a huge clinical study. It's actually in the US all over and even in Canada. And so it's run through a cooperative group, meaning like, a ton of different research sites. The idea of this study is for patients with CLL who would otherwise be on active surveillance or watch and wait. If the patients have high risk CLL, meaning these are patients who are most likely going to need treatment anyway over the next 3 years, what we do is patients get randomized to either do treatment right away or do treatment when you would usually do treatment. It's not exactly a placebo study. The patients who get randomized to delayed care are patients who would be doing what we'd be doing anyway, which is waiting until the CLL causes symptoms to treat the disease. The patients who get randomized to early treatment do treatment right away. And so what we're testing is whether doing early treatment in the high risk patients can lead to these patients living longer. We don't know if that will be the case or not. That's the purpose of the study. There are risks to doing a study like this because this treatment can, cause side effects. The big risk is generally infection, but I think it is a good study to see, can we change our standard of care and prove that early treatment is beneficial. I think there's maybe around close to 300 patients that we're looking for this study. And I think we've gotten maybe around 55 to 60% of the patients we're looking for. So we're continuing to recruit patients for this study. And we probably won't see results on it for maybe another 5, or so years, because it takes a while to see, well, how do patients do? Did the patients that got early treatment do better or not? Patients who go on this study are usually excited about getting early treatment. And so that was part of the reason for the 2-to-1 randomization. What that means is that for every 3 patients that participate in the study, 2 get early treatment for every 1 that gets delayed treatment. The other nice thing about the study is that the study pays for the drugs. So, that part's nice.
And then the other question was, um, sorry, there were 2 questions on the,
Oh,
having
yes,
achieved,
the anemia.
and yeah,
Yeah, so with the venetoclax obinutuzumab regimen, I will say that I've commonly seen patients with delayed recovery of blood counts. Um, Not a ton, but maybe 1 out of 10 patients. In my experience, it's usually the white cells that stay low, occasionally the platelets. With the red cells staying low, if obviously I'd have to see your records, but I would want to make sure that there's not some other cause of anemia. So assuming other causes have been ruled out, it could be just a delayed side effect from the treatment, because that happens maybe 1 out of 10 patients.
great. One person is asking if you can re-show the slide with the various other treatments under study.
Oh yeah.
And then others are asking if you'll be sharing the slides. And I believe you said prior to this that you're open to sharing. So I will make sure that those slides are attached or also posted with the video on our website. So you'll have access to them after this. There were a couple of questions earlier, through registration, and one here now about other cancers, whether they're for the patient or in other family members. So maybe like this one in particular, my father died from non-Hodgkin's lymphoma. I was told there was no connection to my CLL. What do you think? And then other questions have also come in on that general topic.
Yeah, I used to have a slide related to that. I cut that one out. So there is, oh no, here it is. So what we know is that the risk of other cancers is the patient. So patients with CLL have a higher rate of other cancers. The highest risk is skin cancers. And so patients with CLL probably around 6 to 7 times more likely to get skin cancer. And so I do recommend everyone goes to a dermatologist at least once a year for a full skin check. Avoid lifestyle changes that can increase risk for cancer, such as smoking. You should wear sunscreen, etc. Um, as far as the other types of cancers, it's not a dramatically elevated risk like colon cancer, breast cancer, prostate cancer, but it is enough of a risk that you should just stay up to date on what's called the age-appropriate cancer screenings. So, kind of the things that your primary care doctor talks to you about. I also had a slide before related to the familial risk of CLL. And so there probably is a little bit of a link to the person whose family member had Hodgkin's lymphoma. What we know is that patients with CLL can have an increased risk of other lymphomas in their family. It's not a super high risk. However, we do see some families where like multiple relatives have CLL or other lymphomas. Um, it there's not a test to look for that. So it's not like breast cancer where you can just test for the BRCA gene. It's actually likely related to like, a dozen or more different little kind of small genetic markers that there's no standard test for. But in my own patients, I have one 40-year-old woman who had CLL, has family with CLL, and I think it'd be reasonable for her kids to get checked for their blood counts maybe a little earlier than you normally would. But there's no otherwise standard guidance. It probably is about 5 to 10% of people with CLL that have what we would informally called familial CLL, meaning that the lymphomas look like they run in this person's family.
I will say that we in early early May had a webinar on exactly that topic. And I would strongly encourage everyone who has an interest in understanding more about, any sort of links or potential links to other family cancers to watch that video. I just posted a link in the chat to that video, but it's also like all of our webinars, there are recordings available on our website. So thanks for those questions. That's a great one. Okay, so I am going to, there's one person who mentioned they have both CML and CLL. Is that a thing? How does that
I've
happen?
seen that twice. Yeah, so I don't know if I've seen more than the average doctor just because I'm a quote leukemia specialist. I actually do also see CML. I don't see a lot of the acute leukemias, but I do see some other chronic leukemias. The other combo I've seen a lot of is CLL and MDS, myelodysplastic syndrome. I'm hoping we start to see less of that because one of the reasons CLL patients are prone to MDS is it can be caused by some of the chemos that we used to use, like FCR. That actually causes MDS. So I'm seeing less of that, but even without that, there does seem to be a little bit of a link between CLL and other cancers. And yeah, personally, I've seen two people with that I can recall with CLL and CML.
Okay, great. And generally speaking, there have been a few questions that have been submitted about kind of long-term outlook. And I realize that this completely differs by patient and by, age, lots of other factors go into this, but maybe you could just kind of talk about how patients, maybe when you have an encounter with a new patient, for example, how do you kind of walk through that dialogue about, kind of outlook for the future?
Yeah, when I meet new patients, I think it's common to see a lot of anxiety, which I think is totally normal. This is a life-changing diagnosis, and none of us have been smart enough to cure it, meaning it's something you'll have for the rest of your life. And so I understand the anxiety. What I try to do is provide reassurance because, yes, you do have this. However, with that being said, it's pretty rare for me to have a patient die from CLL. And so my goal is always to get you to whatever your normal lifespan would be without the CLL. And I would say almost always we can achieve that. The reason that is now possible is because the treatments that we have now are so good that most of the time I'm not seeing people die from the CLL. It's not impossible. And so sometimes, there can be bad outcomes. The one that's still very tough, even in today's day and age, is when patient CLL morphs into a more aggressive lymphoma. That's called a Richter's transformation. That's an area where our treatments still don't work the way that, we would hope. But that's uncommon. Maybe only 5% of people or so end up with that. Otherwise, though, CLL is extremely treatable, and because our approaches are so much better, I think our goal needs to be, kind of minimizing as much as possible the disruptions to quality of life, minimizing toxicity, and hopefully minimizing the risk for infection. And so that's not always easily done, but I do encourage my patients to stay up to date on the vaccines that they're able to receive. So Lindsay, another question that came to us, actually two patients had the question related to the MMR vaccine. So we don't recommend live vaccines, but the non-live vaccines, it's the best protection you can get to kind of stay up to date on your vaccines. And it's always better to get vaccines before you start treatment, because once you start treatment, the body doesn't respond as well to the vaccines. The MMR outbreak is really frustrating for a lot of reasons, but one of the frustrations is that my CLL patients can't really safely receive the live vaccines. And so the best advice I have is to just avoid anyone with any potential symptoms of infection, to protect yourself from, these measles outbreaks that have come about, because ultimately they, get spread from infected people. But it's really a shame that, we're not able to protect our most vulnerable members of society. There's something called herd immunity. The idea is like, well, not everyone can get vaccinated, but if most people get vaccinated, then that protects like the herd, so to speak. And so that's why, even though for years and years, not everyone could safely get a vaccine like the MMR, because almost everyone did get it, that's why we almost never saw cases. And so that's changed a bit. I hope it doesn't get worse, and I hope it gets better.
So just to restate, it sounds like what you're saying is if you have not started treatment, you should get the measles vaccination. You should, if you, okay.
No, you should never. We recommend to completely stay away from live vaccines, even with or without treatment.
Oh, okay.
There's a
I see.
risk of they're just not worth the risk, unfortunately, because they can cause infection themselves. So that
Okay.
it's a never for live vaccines.
Okay.
But all the other vaccines, which is most of the adult vaccines, are
Okay.
not live. And so
Okay.
like the flu, the RSV, the pneumonia, I'm
Yeah.
blanking, the
Okay.
pneumococcal, etc. Yeah, but the lives are a no-go.
Okay.
Just may not be
Great.
safe.
Okay, we did have a couple of questions about tests, and I wanted to, we're running close to time here, so I'm gonna ask you, generally speaking, one question we got was, do you recommend fish testing for new patients? Also, I wanted to clarify, you talked about the MRD test, so can you talk a little bit about what that test is? So that maybe it's called something by, and people might be familiar with the test by a different name. And I'll also just point out that we do have some information about the tests and on our website, so people can maybe take a look if they have questions after the fact on testing.
Yeah, so I do recommend fish. I usually send it when patients are diagnosed. And the reason I send it is I like to know, is this a low risk patient? Is this a high risk patient? And the other test that's helpful to know, are you in this bucket or that bucket, is the IGHV test. The IGHV never changes, so you actually never have to repeat that. However, the fish can change as you've gotten multiple treatments. And so that is one that I repeat, if you're a patient who needs multiple treatments. Um, in theory, if you don't have any symptoms from your CLL, you could make an argument to, well, why don't we wait till you have symptoms and then we'll test you? And I don't think that's actually wrong. Um, the reason I like to send it a little early is because I'm participating in this study looking at early intervention, and I wouldn't know who's eligible unless I kind of figured out, okay, which of my patients are high risk. That being said, is when I meet patients, if it's someone who kind of just doesn't want to know, then I don't force them to send it. So I actually have a discussion, but my general recommendation is, hey, let's send this to see if you're eligible for this trial, unless it's something they just wouldn't want to do anyway, and then we don't send it. MRD, the other test you may have heard is called clonoSEQ. So clonoSEQ is kind of like the Cadillac of MRD tests. It looks for CLL cells at a 1 to a million resolution. So there's different levels of how deep of a haystack we're looking for this CLL needle. So clonoSEQ is looking at 1 to a million resolution, and that test is FDA approved for whatever reason. It doesn't always mean insurance covers it because it's probably the most costly test. There also are more kind of, I would say, less expensive ways of testing for MRD, but they only look at the 1 to 10,000 level, and that's usually flow-based MRD, flow cytometry based, but that also still has to be sent to a specialized lab. So we send ours to the University of Washington. When I was at UNC, we sent ours to Mayo. Some big places like MD Anderson and Sloan Kettering, where I did my fellowship training, they do it on their own, but it's run by generally specialized labs to look for
Great.
tiny little bits of CLL.
Okay, great. Okay, we are going to start wrapping things up here. If you wouldn't mind, stop sharing your slides, and I'm going to share
Sure.
my own. And just remind everyone that we do have two more programs coming in this new and emerging treatments series. If you'd like to register, you're welcome to do so. You can do that on our website. And then, as I mentioned earlier, we have some information about diseases, but also about the testing. And we have the webinars all on our website, so please do visit if you would like to learn some more. And I'd like to thank Dr. Coombs for the preparation that went into this. And I think it was a really great talk. Lots of questions answered. Did you have any final things you wanted to share, or thoughts, or any questions that jump out at you that we didn't get to that you might want to knock into real quick?
Yeah, the funny one relates to my name. So there's a test called the Coombs test that's used in actually CLL, and someone asked me if I'm related to that Coombs. I don't think so. And then I saw someone else in the webinar has the last name Coombs, but they're from Oklahoma. So I'm from the Ohio Coombeses. So I don't know that we're related either. It's not that common of a last name though. So I
Great.
just was laughing about those questions.
Yeah, I love it. Well, thank you so much again for everything, and we really appreciate it. And one reminder to everyone today, don't forget to look out for that email with the link to the survey to just give us some feedback on the program. Hopefully everyone got something out of it. And we would really appreciate everyone's attendance. And thank you so much, Dr. Coombs.
All right, thank
Have
you,
a
everyone.
great
Have a
day.
great day. Bye.
Bye.